My name is Dr. Megan Piper. I'm a clinical psychologist and part of the University of Wisconsin Center for Tobacco Research and Intervention. And today, along with Kristin Berg, I'm going to be talking about addiction, treating a chronic disease. This is a special presentation we put together specifically for Women's Health Foundation First Breath program. So I hope this is going to hit a lot of the issues and concerns and questions you may have, and we will take some questions at the end. So first, what we're going to talk about today are primarily the two most common addictions, and that is alcohol and tobacco. At this point in the United States, about 18% of adults smoke, and that is down considerably from where we've been in the past. In fact, it's the lowest in the modern era. So that is really exciting to see. And we are still currently at more than half of adults drinking in the United States. So again, with those being the two most common addictions, the ones that people see and hear most about, and probably the ones that are most commonly presented to you in your practices, that's what we're going to focus on today. So first thing we're going to talk about is habit versus addiction. We're going to talk about the distinctions, how they're similar, but also how they're different. We're going to look at the scope of the problem, a little bit more detail about who's using tobacco, who's drinking, and both across the United States as well as in Wisconsin. And finally, we're going to get into the meat of the issue, screening and treatment. How do you look for, assess, identify patients that need treatment for tobacco and alcohol, and then what do you do with those patients, whether they're ready to quit at this point or not? And of course, a lot of these will be focused on pregnancy and dealing with women pregnant or just recently postpartum. So let's talk about habit versus addiction. Think in your head what kind of bad habits you have. What are some things that you do that you really wish you didn't do? Or maybe these are things you did when you were younger, but you don't do them anymore. You know, who bit their nails when they were growing up? Or who was a knuckle cracker? Has anybody ever been a nose picker? That's not something you probably want to admit to the person sitting next to you, but we've all had bad habits. Procrastination, I would be guilty of that one. Overspending, that sort of thing. Now these are habits and things that you do on a regular basis, and we'll talk about how a bad habit, something that's maybe inappropriate or not so socially acceptable, is different from an addiction. Because when we're talking about addictions, we're talking about using substances like alcohol, tobacco, caffeine, other drugs of abuse, cocaine, heroin, meth, gambling, sex, exercise, and how important it is to think about when you're treating a woman who's coming in to see you for an addiction for tobacco or alcohol, how that's different than just a bad habit that she should be able to stop. So the first thing we're going to talk about is something called automaticity. This is this idea that you can just do something on autopilot without thinking about it. The example I give for smokers is sometimes they smoke a cigarette, they're smoking a cigarette, and they go on and they light a cigarette. They already have one burning in the ashtray. They weren't even thinking about it, they just did it. One that might be familiar to you is you're really busy from a day of work and you're driving home, and you realize you're halfway there and you don't remember making any conscious decisions to turn or change lanes or do whatever it is you do because you're just on autopilot. So when you're engaged in something automatic like that, you actually have to bring that behavior into conscious awareness to be able to change it. Because if you're on autopilot, you can't change. You've got to be very aware of all the decisions you're making. And that is something both habit and addiction have in common. A lot of people talk about, I was a nail biter and I stopped, but then it got real stressful and all of a sudden I look down and I have no nails because you did it on autopilot. You have to be aware. A lot of times, again, drinkers will say, I finished that fifth before I was even aware that I had taken more than one drink. Another issue to think about when we think about habit versus addiction is something called positive reinforcement. That's the buzz you get, the good feelings that you get. And what this comes from is Thorndike's law of effect, is the psychological term for it. What it means is if it feels good, you're going to do it more, right? If we enjoy something, we want to do more and more of it. And that's true of a habit. A habit can be enjoyable. Sometimes people like the feeling of cracking their knuckles. That feels like a good release. But addiction is much, much more enjoyable. The positive reinforcement, the buzz, the good feelings you get from an addiction are much greater. Because what happens is when you use an addictive substance of any nature, it actually produces a dopamine surge in your brain. Okay, so your brain actually has this reaction that is pleasurable. And there's a whole part of your brain whose whole job is to regulate pleasure. And when the dopamine gets in there, it really makes things feel good. Now, with addictive substances, one of the issues is how quickly it gets to your brain. Nicotine gets to your brain in 6 seconds and starts the buzz in 6 seconds. That's what makes nicotine so incredibly addictive. If you think about the difference between cocaine when it's snorted, right? That was an addictive problem. And then, what was it, late 80s, we had the onset of crack, and that's inhaled. And crack became so much more addictive. It's more addictive because it's inhaled and gets to the brain faster than things that are snorted. So in this respect, nicotine getting to your brain in 6 seconds becomes incredibly addictive. And what happens when it's in your brain, when nicotine is bathing your brain actually changes. You get something called neural adaptation. So if these little green guys are nicotine receptors and the holes are just waiting, what happens is, when there's more nicotine, they grow more receptors. Your brain says, oh, I have this much nicotine all the time, I probably need more receptors in there. So all of a sudden you have so many more green receptors to be occupied by the red nicotine molecules. So this happens for nicotine receptors, and it also happens for the dopamine receptors in your brain. So that means that now, when something pleasurable happens, like let's say you see a cute baby or you see a puppy, there's dopamine in your brain, but all of a sudden, is there really enough dopamine to occupy all of these different receptors? And if there's not, that could be a problem. All of a sudden, the things that used to be rewarding and pleasurable might not feel as pleasurable as they used to. And because you get neural adaptation, because your brain actually changes, you get something called tolerance. Tolerance is defined 2 different ways. One is that you need to use more of the drug in order to feel the effects. So that would be something along the lines of when you first started drinking alcohol, perhaps it only took 1 drink for you to feel a little bit of a buzz. And if you drink on a more regular basis, it now takes more drinks for you to feel that kind of buzz. The other definition is that you can use more of it without getting sick. The tobacco example is perfect here, right? The first time somebody smokes a cigarette, many times they feel nauseous, they may vomit, but over time they stop having that reaction and they just start feeling the other effects of the tobacco. Now when it comes to habit, we don't develop tolerance. There's no tolerance developed in your fingernails unless your fingernails just get weaker as you bite them. There's no tolerance developed in your knuckles or when you pick your nose. You can still do that at the same rate, same experience. But with addiction, this is definitely holds. You need more and more of the drug over time to feel the effects, and you don't feel the negative effects in terms of initial use, like you don't get nauseated when you smoke. Again, because you have this neural adaptation, because your brain has changed in the course of this addiction, and you've developed tolerance, you have withdrawal. Your brain notices when there's not enough drug on board, and it says, hey, we need more, our brain needs more, and it will invoke different symptoms. It will invoke craving, it will invoke negative affect, it will invoke irritability, it will invoke difficulty concentrating on anything except obtaining the addictive substance, okay? And that is withdrawal. And it can even be something, not just falling levels in the brain, but if you're in situations where you usually use and you're not using there, even, let's say I smoked a cigarette before I went bowling, and then I go into the bowling alley, and I used to always smoke with my bowling buddies, I can have cravings and withdrawal there just because that's the environment that I'm in, okay? Or let's say I'm out with friends, and I had a cigarette before I went out, but now I'm out with my friends, and they're all smoking, and that makes me want to smoke because I'm used to doing that ritual, and that is part of the addiction, and I have withdrawal symptoms. So when you think about tobacco withdrawal, craving is huge. Negative affect, loss of concentration, difficulty sleeping, hunger, those are all withdrawal symptoms. And sometimes people will say, well, really? With tobacco withdrawal, it's not that big a deal, right? Especially compared to alcohol withdrawal, which can be life-threatening. But we talk about sometimes people feeling like they've lost their best friend. It's almost like they're in mourning. They've given up the one thing that's been with them through all of their hard times, their divorce, their marriage, their graduation, their loss of their job. It is reliable and it's always there. And it can have huge consequences. The cravings can be climbing the wall types of cravings, the likes of which you would expect to see in a heroin addiction can happen. With respect to negative affect, I talk about irritability a lot with people. I worked with one woman an older woman, and she was a great knitter, and she came in a week after her quit date, and she was very upset because she'd been talking to her sister on the phone, and she'd gotten upset with her sister, and she'd hung up and put her phone through the wall. So it's not just I'm a little touchy, it can be incredible irritation. So it's important to treat that. It's important to treat withdrawal for both tobacco and then also for alcohol. Alcohol withdrawal looks very similar. You get craving, you get anxiety, you can have seizures, delirium tremens, and again, it can be life-threatening and may need to be medically managed, so that's something that you need to think about. But when you're helping somebody get off either of these substances, withdrawal is a necessary component that you'll need to address. And again, you don't have withdrawal from habit, not so much. You don't have a physiological reaction to not having it, but you certainly do with addiction. Negative reinforcement. This is another place where we can look at habit versus addiction. Negative reinforcement is something that makes you feel better when you're feeling bad. Now, you can feel bad for lots of reasons, right? You can feel bad because you just had a fight with your best friend, or you can feel bad because you don't have enough drug in your system, and it's a withdrawal-related bad feeling. Either way, when you use drug, you can feel better, okay? And that can be very reinforcing. In fact, a lot of models of addiction talk about the negative reinforcement model. People don't have enough drug, or they're not using drug in a place where they usually do, makes them feel bad, makes them crave, and then they use drug and feel better. And that's how the cycle sort of perpetuates itself. Now, habit can also make you feel better if you feel bad, right? If that's your coping response when you're tense or anxious, maybe before the talk I was sitting back there going like this, chewing on my fingernails because I was nervous, and it might have helped me calm down as a coping response. But I'm certainly not feeling bad if I can't chew my fingernails. Loss of control. This is probably the biggest difference that I really hope people get out of this talk today. And that is the idea that with habit, it's not that you've lost control. If somebody pointed out to you that you were chewing your fingernails, you could probably stop, right? If somebody pointed out that you were smoking a cigarette or drinking too much, it's not likely you can stop without help, okay? When things feel like they've lost control, and most smokers will tell you they know they've lost control. They know it's bad for their health, and they do it anyway. And why? Because they've lost control over the addiction. With drinking, it's a little bit different. With drinking, sometimes part of the treatment is to get them to acknowledge that they've lost control. Oh, you tried to have just one drink, and you keep ending up having, the entire six-pack or the entire bottle. That's a loss of control, and it takes some people a while to understand that they've lost control. Because then, once they understand that they don't have the control, then they really are identifying as being an addict. Addicted to tobacco, addicted to alcohol, whatever. But the idea is when you continue to use when you don't want to, that illustrates the loss of control. So again, when we think about habit versus addiction, habit and addiction, they're both automatic. They're both things you can do without thinking about it. There's some positive reinforcement, right? For sure you get a buzz from the addiction substances. Habit can feel good, can feel stress relieving. And that also is consistent with some negative reinforcement, right? If you're feeling bad, maybe that's something that makes you feel better. But when it comes to addiction, we have actual tolerance. We have physiological changes in the brain and the body that allow you to use more of the substance. We have withdrawal. When you don't use the substance, your body reacts to that, and it does what it needs to try to get you to get back into using the addictive substance. And that means you've lost control, because your body is telling you, I need a cigarette now, and in many times, without help and support, you do have no control over that. And so what we want to talk about is how you are going to be treating addiction. I know it doesn't seem like tobacco, it's a legal substance. If you're over 18, you can get it. It's highly, highly addictive. And it will kill you. It is the only legal substance that when used as directed will kill more than half of the people who use it. So what we've got as we think about this as a true addiction is this is the diagnostic criteria. Okay, so DSM-5 revised the diagnostic criteria. They used to have substance abuse and dependence, and now they just have substance use disorder. The first part is impaired control, which we talked about, right? When you have that loss of control. It's taking a substance in larger amounts or over longer periods of time. It's a persistent desire to cut down our use, but you can't seem to do it. You spend a lot of time obtaining, using, and recovering from the substance more than you had anticipated. This tends to become more of an issue for alcohol than it does for tobacco. And craving at any time, especially when there are environmental cues, and we talked about how important that can be. Social impairment. Failure to fulfill major obligations at work, school, or home. Again, this is less of an issue for tobacco because it's non-intoxicating and because you can use it just about anywhere. But certainly for alcohol, when you notice that people aren't, perhaps women aren't able to get to work, or they're late for work a lot, or their kids are late for school, those kinds of things that just don't seem to be done because they're either using or they're recovering from using. Substance use that continues despite social problems. So people are commenting, maybe, why are you always stepping out at the bar to go have a cigarette? We're all in here hanging out, and you keep leaving the group. You're not fitting in as well. And then other things that are given up in order to use substances. Risky use, recurrent use in physically hazardous situations, despite physical problems. Now, recurrent use in hazardous situations more likely to be an alcohol issue for sure, but continued use despite physical or psychological problems, every smoker knows it will kill them. Every single smoker, whether they've rationalized it or said, not me, or my grandma Minnie used to smoke and drink every day until she was 95 when she was hit by a bus. Everybody has their stories, but they know it will kill them. Alcohol, not quite as much. Alcohol, you're usually dealing with either somebody has an alcohol-related disease, or if she's pregnant and she's continuing to use, knowing the damage it can be doing to the fetus as well as to her health, then you've got somebody that's in a risky use criteria. Pharmacologic criteria, we talked about tolerance and withdrawal. Both of those can be present. So what they do, instead of separating abuse and dependence now, is they just use severity. So if you have 2 or 3 of the symptoms we just reviewed, that'd be mild, 4 to 5 would be moderate, 6 or more would be severe. But what I would also reinforce is that anybody that comes to you and says, I smoke and I don't want to, and I drink and I don't want to, I don't care how severe it is, they're asking for your help. And for the most part, women who know that it's bad for their baby and are still doing those behaviors really do have an addiction they can't stop without your help. So in terms of the scope of the problem, again, like I said, we're looking at about 18% of adults in the United States smoking as of 2012. Those are the 2012 numbers. A little bit more than women smoke. We still have about 12% of pregnant women smoking, but the highest group really are people with mental illness. And so that's something else to be thinking about. How is mental illness combining with tobacco and alcohol use in your patients to make things really hard for them to be as healthy as they want to be? And how can you work to help that? If you think about Wisconsin, actually we have a little bit higher smoking rates. We're at about 20%. The gender difference is a little smaller between men and women. 13% of pregnant women are smoking at this point. We have about 40% of people who are ever diagnosed with depression are smoking. And of course, socioeconomic status is a big predictor of smoking. People in lower socioeconomic status are much more likely to be smoking. We're talking 33% versus 20% of the general population. So again, that's another issue. When your clients come to you, these are women who may have mental health issues. They obviously are lower socioeconomic status and are needing extra help. And so this is a group we really have to work hard to get them the treatment that they need and the support that they need so that they can beat the addiction. And there are also racial differences and ethnic differences that we have here in Wisconsin in terms of smoking. When it comes to drinking, remember I said earlier that a little over half of the adults in the United States drink. Here in Wisconsin it's 66%. We've made it all the way up to 2/3. We have the highest binge drinking rate in the United States, so 22% of adults binge drink. By definition, that's 5 or more cigarettes for men, or 5 or more drinks at a sitting for men, and 4 or more for women, taking into account body mass. About 6% of Wisconsin drinkers are heavy drinkers, and that means for men they're drinking 2 or more drinks a day. For women, they're drinking 1 or more drinks every single day. And at this point, about 9% of pregnant women are reporting alcohol use in the last 3 months of pregnancy. So again, binge drinking is probably the most common form of problem drinking that we see. It's more common when in the younger age group, and it's also, interestingly, more common in higher socioeconomic status. What's common in the lower socioeconomic status is that they do it more frequently. Fewer people are doing it, but when they do binge drink, they're binge drinking more frequently, and they're drinking a lot more than 5 or 4 drinks per day. Okay, so that's the thing that you want to be thinking about. The women that are coming to see you, is she binge drinking? Is she having more than 4 a day? And is she doing it a lot? And are you seeing a lot more than 4? Is she, drinking an entire bottle of wine, which would be 4 or 5 glasses, or an entire fifth, or, however much beer? So, like I said, we're talking about addiction here today, not habit. We're talking about something that is disproportionately affecting women of low socioeconomic status, women who are not white, women with mental health issues, and so addiction, being very different from habit, is definitely something that needs treatment from providers such as yourselves. So with that, I'm going to turn it over to Kristin Berg, who's an internal medicine physician at the University of Wisconsin, and she also works at the Center for Tobacco Research and Intervention, and she's going to talk about treating addiction.
Thank you. Okay, hi everybody. Thank you very much, Dr. Piper, for that excellent background. And I think now that we have that frame of reference for just the differences between addiction and habit, we'll talk a little bit about treating addiction and the effect that you guys can have on your patients. So, treating addiction is really hard. Without assistance, as far as smokers go, only 3 to 7% of smokers who attempt to quit smoking will be successful at the 1-year mark. So that's really low numbers, but with optimal treatment, that number will improve 4 to 10-fold to about 30% of smokers who get that optimal treatment, and I'll tell you what that is, being able to remain smoke-free at that year point. Similar numbers with trying to quit alcohol use and quitting drinking. With optimal therapy, you're getting numbers in the 40 to almost 50% range that people can help their addiction and change their life. So for the next part of the talk, I'm going to go through tobacco treatment and alcohol treatment separately. And I'm going to be using the 5 A's framework, which are a little bit different for both of these substances, but they give a really nice evidence-based framework to go through. So the 5 A's for tobacco treatment are ask, advise, assess, assist, and arrange. So as far as asking about tobacco use, you're asking every patient every visit. Healthcare organizations are encouraged to use this as a vital sign. So along with your blood pressure, your heart rate, your temperature, what's your tobacco use status? Are you a current user? Have you quit? Or a never user? When you're advising patients who are using tobacco or who have quit, you want to be using clear, strong, personalized advice to quit. That personalized piece is really important. There's been a lot of evidence that shows that really puts it in the context of the patient's situation and really helps them incorporate that advice that you're giving them. So statements like quitting smoking is the best thing that you can do for your chronic bronchitis just really helps to kind of make that advice a home run. And we know that this works. Brief advice from physicians increases the odds of quitting, and in pregnant patients, early smoking cessation advice will increase the odds of that woman quitting or cutting down her cigarette use by more than 50%. So just a huge impact that you can have just by assessing and advising your patients. As far as the 3rd A, the assess, you're asking if they're ready to make a quit attempt. And this is kind of daunting, how do I bring this up? How do I ask, are you ready to make a quit attempt? So some of the things that Dr. Piper and I like to use are you interested in making a quit attempt today? How do you feel about trying to quit? Or would you be willing to talk about different treatments for quitting? And this really kind of puts the ball in the patient's court. It lets them know that they're in control of the conversation, of the situation. You're not demanding that they quit smoking. You're not being demeaning towards their smoking. You're opening the door for that conversation to happen. So if they are ready to make a change, first thing you do is congratulate them. That's a huge step that they're taking. It's a big change. It's a lot of work that they're going to be going through. So you really want to make sure that you're congratulating those patients that are ready to make that change. And then we can start talking a little bit about the tobacco specific treatments, and those kind of fall into 2 major camps, counseling and medications. And then for any of those patients who want additional resources or maybe want to go on their own and kind of think things through themselves and maybe make up their own plan, we'll go through some additional resources for them too. As far as counseling and medications go, we know that counseling is good and medications are good, but it's really the combination of those two things that give your patients the best shot they have in reaching those, a third of patients with the optimal treatment will quit smoking at a year. So really you're talking about both the counseling and the medications that you're going to be offering to patients. As far as the counseling points go, there's kind of three main tenets that you're going to be hitting. There's setting a quit date, reviewing past attempts, and then anticipating the triggers that they're going to come across and ways to kind of cope with them. So as far as some of the pearls for when you're talking about setting a quit date, you're getting rid of all the tobacco products. So you're basically making it harder for the patient to reinstate their smoking habits or their smoking addictions. So you're getting rid of all the cigarettes, all of the lighters, all of the ashtrays, so that if they want to have a cigarette, they have to go to the store, buy the cigarettes, buy the lighters, everything like that. It just kind of makes them think a little bit more. It's not as easy to just grab that cigarette. And they pledge to themselves and their family and friends, if they're involved in the equation, no cigarettes, not even a puff, after you wake up on that quit date. That's a hard and fast quit date. So that's, like I said, that's a promise to themselves. With reviewing past quit attempts, you're talking about what worked for them. Some patients will quit with friends so that they have someone to commiserate all of the withdrawal symptoms and everything with. There's some patients that will save the money that they would be spending on cigarettes and put that into a fund to buy something really expensive or out of the ordinary for them. So it's like a nice treat when they reach their goal quit time. And then you're also talking about what led to past relapses if they've tried to quit in the past and haven't been successful. Getting them to kind of verbalize and recognize the problems that they had so that when those problems likely come up again, they're ready to handle them and kind of push through them and hopefully have developed some additional coping strategies to make this quit attempt successful. For anticipating triggers and ways to cope, things that you want to touch base on are the weight gain. Unfortunately, there is a weight gain associated with quitting smoking. It's usually about 5 pounds. Environmental cues, so what they can do when they're driving a car and they're used to smoking a cigarette while they're driving or having their morning cup of coffee, so that they can kind of start to think about how can I replace that automatic lighting up a cigarette, what can I do to help not do that? Being around other smokers is difficult, so talking with their friends and family, if they have friends and family that smoke, and getting their support and saying, hey, let's try not to smoke when you guys are around me, and ways to manage with being around other smokers when that does happen. Alcohol use is another big thing to touch on when you're talking about triggers for smoking, because like Dr. Piper said, with the alcohol and any addictive substance, it increases the level of dopamine in your brain, and there's kind of a kindling effect. So if you get a little bit of dopamine, all of a sudden your brain is going to want a lot more dopamine, and one of the easiest ways to get that is by getting a cigarette. So making sure that we're talking about alcohol use and kind of the consequences that can happen when people are trying to quit smoking. As far as medications go, there's really 3 big groups of medications, I'd say. There are technically 7 FDA-approved medications, but these kind of fall into 3 big groups. So there's combination nicotine replacement, we'll touch on all of these individually, Varenicline and Bupropion. Technically these are all first-line agents, but I think if you talk with a lot of the smoking cessation experts, the literature and the results are starting to show that it's probably more likely to be the combination nicotine replacement and Varenicline as being the most efficacious medications out there for patients. So when I'm talking about combination nicotine replacement, I'm talking about both a long-acting nicotine replacement and a short-acting nicotine replacement. So the long-acting are the patches, and these are dosed based on number of cigarettes smoked per day in the patient. So if they're smoking more than 10 cigarettes a day, you're giving them the highest strength patch. Short-acting are things like the lozenges or the mini lozenge, gum, inhaler, and nasal spray. And the lozenges and gum are the ones that are available over the counter, as are the patches. The short-acting versions are based dose-wise on how soon after waking that the patient has their first cigarette of the day. So if it's within 30 minutes, they qualify for the 4 milligram, the highest dose, short-acting. And to use these in combination, the idea is you have this kind of chronic low-level amount of nicotine in the system from the patch, but then they're also using these short-acting to get the bursts of nicotine when they need it. And most people will advise their patients to use them on a schedule initially and then on an as-needed basis, so that they're really, when they have a craving, they've got something to use that isn't a cigarette. These things are started on the quit day, and length of use usually around 12 to 14 weeks, but really kind of depends. It's most individualized based on patient needs and the difficulty that they're having with quitting that addiction. As far as Varenicline goes, this is a nicotine receptor agonist and antagonist. So what this means is that the drug will bind to those nicotine receptors in the brain, produce a little bit of dopamine so that it kind of helps to combat those withdrawal symptoms, but it also, in occupying those receptors, if you do smoke, that nicotine from the cigarette can't get at those receptors. So all of a sudden smoking doesn't produce the same rush that it used to for you, and it's not as pleasurable of an activity. So for that reason, we do not combine this with nicotine replacement therapies. And this medication is started about a week before the quit date to allow the medication to build up in the system, and then the patient quits and they're just on the Varenicline for about a 12-week course is kind of the usual time frame there. You do need to have some consideration as far as who this medication would be appropriate for. You want to definitely use caution in patients with kidney disease, but also unstable heart disease, coronary artery disease, and severe psychiatric illness. So this medication is not available over the counter, it's only available by prescription, and you do need to have some consideration, like I said, about who you're prescribing this medicine for. Bupropion is the last first-line treatment, and this is an antidepressant, so it works to help reduce those cravings and kind of the negative affect that you get with the withdrawal symptom. Likewise, this is also started about a week before your quit date, and then it's about a 12-week course or so. And in this, you also have to have some judgment as far as who is most appropriate for this medication. You're going to want to be cautious in anybody with a seizure disorder or conditions that increase the likelihood of seizures, so things like heavy alcohol use, use of benzodiazepines, things like that, and then anybody with severe psychiatric illness because it is an antidepressant. So again, good medication, probably less efficacious with some of the newer evidence that's coming out, and does need to have some consideration as far as who this medication is appropriate for. Medications in pregnancy is a tricky subject. There is some research out there, and kind of the best information that I can give you is that it's best if she is able to quit on her own or with counseling, but if you really think that she's not going to be able to quit, or if you think that the lack of medication is really going to hinder her, then either nicotine replacement therapy or bupropion are the two most commonly used medications when someone is pregnant. We always want to discuss the risks and benefits of smoking cessation medications versus smoking. They're both chemicals. I think you have more chemicals if you're smoking a cigarette, but you still have the intake of chemicals, and there's not super great research on what happens to both mom and baby taking these medicines. So if you do have to use them, you're using the smallest effective dose for the shortest time possible. So what a lot of people will try to do is just do the ad-lib treatment, where they're using those short-acting lozenges or gum, lowest dose, only when you have cravings, and then it's not a continuous supply of medication if you have the patch, and hopefully using it for a really short time. But again, you've got to have that discussion about risks and benefits to mom and baby. The additional resources that I alluded to earlier, there's a couple of really great ones out there. I really like the smokefree.gov website. I think it's a very nice, patient-centered, in-depth website that goes through some of the strategies and gives patients a lot of really great information. There's 1-800-QUIT-NOW, that's the national tobacco quit line. Each state has their state-run quit lines, so if you called 1-800-QUIT-NOW in Wisconsin, you're automatically sent to Wisconsin's quit line. They offer free telephone counseling sessions as well as 2 weeks of cessation pharmacotherapy. Great resource. And then you can also direct your patients to go to their local hospital or their local healthcare organization, because a lot of the bigger organizations will have smoking cessation treatments in place. Like CTRI, the Center for Tobacco Research and Intervention at the UW. The VA has good smoking cessation protocols and clinics and everything. So having them check with some of their local organizations is another way that they certainly can go. And the big new thing is that with the Affordable Care Act, now insurance you have mandated coverage for 2 quit attempts per year with FDA-approved medications and counseling. So if it's a cost thing that the patients are worried about, hopefully this will start alleviating some of that and will really kind of get folks over that barrier so that it eliminates that barrier to having them quit smoking. If you have patients then that aren't ready to change, when you're assessing them to see if they're ready to make a change and they say, you know, I'm really just not ready for that change, I've got a lot of stress in my life right now, there's a lot of big changes going on, that's okay. You know, it's like Dr. Piper said, treating addiction is tough. It's something that they have to work at and they have to be ready to do. So in this case, there's motivational interviewing. And this is really a decisional balance exercise to help develop discrepancies between what they like about smoking, what they don't like about smoking, and kind of starts them thinking about that change and kind of hopefully getting them ready to make that change. So some common questions that I'll ask folks is what they enjoy about smoking versus what they don't like about smoking. One of the common answers I get is that smoking really helps me to calm down, you know, it helps me manage stress, everything like that, but I don't like smoking because it costs a lot of money, and I don't have a lot of money, so that puts a lot of extra stress on me. So that kind of, then they start to recognize, oh, well, I'm causing a lot of stress because I'm smoking, but smoking helps me alleviate stress, and so it just kind of starts those wheels turning, like I said, and hopefully getting them ready to make those changes. Other questions you can ask them, what would they like about being smoke-free versus what wouldn't they like about quitting? And it's really important to be supportive, to be empathic and non-judgmental when you're having this conversation. Patients need to feel safe, and we'll talk about that in a couple of slides here, but in order to have effective conversations with patients, they have to be comfortable with you, they have to feel safe. So you can't try not to sound demeaning or degrading or, you know, putting their addictions in such a bad light that it just makes them clam up and not want to talk to you. So arranging then is the last step for tobacco treatment, and it's arranging follow-up, and this is extremely important both for the patient and for you as a provider. We know that addictions are a chronic illness, so you have to keep treating them just like you would keep treating high blood pressure or diabetes. It helps patients know that they're not alone when they have follow-up. They say, oh, okay, I'm going to get a phone call in a couple of weeks. This will be really nice to touch base. And it helps providers know that they're not alone. So you're not shouldering all of the callbacks and all the follow-up visits all on your own schedule and everything. It really helps to kind of even out the work. And we know that multiple contacts are always better than single brief interventions. At those follow-up visits, you can also talk about medication adherence. A lot of folks won't use the short-acting nicotine replacement as much as they should, so you can help them kind of use that on a more appropriate schedule to really help with their cravings. And you can also talk about side effects. Maybe they're having side effects from the Varenicline or from the patch, and those medications are no longer the most appropriate medications for them. And finally, you're talking about relapse prevention. So what do you have coming down the next couple of weeks? You know, is anybody graduating? Is there any big job changes, anything like that? So that you're really kind of doing that anticipatory guidance and coping strategies. So shifting gears now into alcohol treatment. We're still going to be going the 5 A's route, but the A's are a little bit different for alcohol. We've got assess, advise, agree, assist, and arrange. So, like I had mentioned previously with the sensitive nature of some of these topics, alcohol in pregnancy is a particularly sensitive area. women know that drinking isn't good for themselves and it isn't good for their baby. So when you're screening patients for alcohol use during pregnancy, you really have to be cognizant of that and allow a safe space to occur to allow that conversation to happen. And so with that, there's different screening tools that have been validated specifically for use in pregnant patients, and one of those is TACE. So this is one that I know my baby and me uses, and we'll talk about their protocol at the next slide, but just to review very briefly, TACE, the T is for tolerance, so how many drinks does it take to make you feel high? More than 2 drinks is positive. Have people annoyed you by criticizing your drinking? Have you ever felt you should cut down on drinking? And have you ever had an eye opener or a drink first thing in the morning to help with nerves or a hangover? And this screen is positive if the patient scores 2 or more points, and you get 2 points for the tolerance question, 1 point for the A, C, and E questions. And so the screen that my baby and me uses is based off of TACE, but it does some really neat things, and I like the My Baby and Me screen a lot. It incorporates a lot of different aspects of the screening process, so you get to understand the patient's knowledge and know where the patient's coming from as far as, do you know the consequences of drinking and smoking, more drinking with pregnancy. It also will assess the frequency, the amount, and the controllability of their alcohol use. It assesses current alcohol use while they're pregnant, and it also assesses for goals, so what the patient wants to accomplish. And then finally, it also allows for educational moments, so it kind of builds in those advising times right during the screen. So just going to go through their screening questions really quick. What do you think about alcohol use during pregnancy? So this isn't, you're not smoking and drinking when you're still pregnant, are you? This isn't that kind of degrading or leading question. This is very just, what do you think about alcohol use? This is getting at their understanding. Describe your alcohol use in the 90 days before you knew you were pregnant. So this is getting at, what were you doing? And it's kind of leading up to these questions that the patient knows are coming, but it's allowing for that safe space and that trust to develop before you're asking the hard questions. Which statement best describes your alcohol use since learning of your pregnancy? So I really like this one because it's not asking, are you drinking? But it is. It's asking it in a very safe, non-leading kind of way. Then you're going through the alcohol screen, and this part is the TACE protocol that we just went through. And then what would you like to see happen with your alcohol use now that you're pregnant? So getting at their goals and what they want to accomplish. And then the last part, asking, can I share some information with you? So this opens up those advising moments and those kind of education about next steps and things like that. So it's a really great screen, and I was happy to be able to go through this. So when you have a patient that you've identified as using alcohol use during pregnancy, the next step is really to advise them. And again, this is cutting down or quitting. Obviously in pregnancy it's going to be to quit, since there's no safe level of drinking associated with being pregnant. And does it work? Absolutely. So you guys really can make a big contribution to your patient's health and their lives by screening and assessing and advising. Brief multi-contact, it's important to know that's not all by physicians. Interventions definitely reduce risky and harmful alcohol use. And again, in pregnant women, brief advice on alcohol cessation validated in multiple studies as being useful and efficacious. When you're agreeing with your patient, you're setting goals, the plans to quit, and then using those motivational interviewing techniques, again, to help those not ready to make that change yet. Assisting with alcohol is a little bit more tricky, because as Dr. Piper alluded to, it is potentially life-threatening if they have alcohol dependence and they're going to be going through that withdrawal. So I would very much recommend a medical evaluation of any patient that you think meets criteria for dependence, if they're a heavy drinker, or if you're worried about them going through withdrawal, to make sure that they're in a safe place when they go through those withdrawal periods. After that, it's the same tenets, counseling and medication for maintenance and treatment after they've gone through the acute detoxification. I'm not going to go through the medications for alcohol use like I did for tobacco. They're not nearly as commonly used, and a lot of times it's very specific providers that are prescribing those medications. Again, we talked about the paucity of evidence for tobacco use in tobacco cessation medications in pregnant patients. There's even less for alcohol cessation medications in pregnant patients. There's maybe one that again kind of carries that you need to have a discussion about the risks and benefits, but you're really making sure that these folks are being treated by specialized providers if they're needing medications for alcohol use. Lots of support groups out there though for patients, Alcoholics Anonymous, Al-Anon for their family members, and then when I was developing these slides I also came across this Rethinking Drinking, and I really like that website. It's by NIAAA. It's got a little bit of an onerous website address, rethinkingdrinking.niaaa.nih.gov, but it's a really nice patient-oriented website, really complete, goes through a lot of information and gives a lot of really great resources for them. So I really liked that website. Again, arranging for follow-up at the end of the visit, very important. And I think these are the exact same bullets I went through with the tobacco use. Chronic condition helps you and the patient know that they're not alone in this. Multiple contacts are definitely better than brief, single interventions. And so, follow-up care of addictions, once you've kind of gotten them through this and you're seeing them back, it's important to remember that addictions are definitely a chronic disease. Relapse happens. Negative affect, like Dr. Piper talked about, might be the most powerful universal withdrawal symptom. So, you hear a lot of times people can get through the physical withdrawal symptoms with, a grain of salt. It's not easy to get through them, but this negative affect piece, the mood, the irritability is really difficult for people to get through. And we know that stress is a hard time for anybody, but women in particular will relapse in times of stress. So relapse happens, negative affect, stressful situations really make it prone to getting those relapse. And it's important just to not be discouraged when relapse happens, because as I'll talk about in a second, it happens just as often in drug addictions as it does in other medical problems. And I'll actually talk about that right now. So, framing, I think, always helps me keep reference to drug addictions and treating drug addictions. So you don't ever really get mad at your patients who have high blood sugar if they have diabetes, or who have an asthma exacerbation if they're asthmatics. Drug addictions relapse with the same rates that all these other chronic medical conditions relapse with. And so helping to kind of keep that frame of mind in reference just helps you not to get discouraged in treating your patients with addictions. And so with all of that really serious talk, I also came across this slide when I was preparing this presentation and just fell in love with it. And so you've got a banana and an apple at a beach. And the banana says, the apple says, I hate it when I'm at the beach and I get grit in my teeth. And the banana says, well, maybe you should just stop eating sand. And so the apple sticks his tongue in the sand and says, oh, right, like it's that easy. So I just had to throw this in somewhere. I didn't really have a better place to throw this in. So in closing, we know that addictions are an illness. Changes occur in the brain, far-reaching implications, and all the different kind of nuances that the brain regions do. They all have changes when people get addicted to substances. It's not a habit. It's not something that patients can just switch off with willpower. And in order to help our patients, we need to identify them. So keeping in mind that addictions cross all ages, genders, cultures, social statuses. You're not screening a particular population, you're screening everybody. And you're screening them with validated tools so that you are catching the patient population that needs to be caught. And your help improves outcomes. So hopefully this talk has shown you some tools that you can use and given you the motivation to keep up your screening efforts, keep up your counseling efforts, because it really makes a huge difference in these patients' lives. The brief multi-contact interventions, medications, and referrals. So knowing what you have to offer patients, knowing your healthcare system, knowing the go-to counseling folks, knowing what community resources are available to you are all really important things to kind of have at your fingertips to help these patients. And then remembering that it's not embarrassing, shameful, or a failure to have a relapse. They happen. And I think both patients and providers need to be reminded of this so that nobody's getting discouraged. You just come back in, we get you back on the bandwagon, and we keep going. With that, we'll close. Thank you very much again for having us talk. Both Dr. Piper and I wish we could be there in person, but thank you for all your efforts, and we'll go ahead and take any questions.